Okay, I'd like to welcome everybody to our NxtGen classroom. Yes, we're in didactic session number 2, where we're going to look at the clinical applications of the orthopedic basic sciences. As you know, last week we spent time looking at vascular and peripheral nerves, and I'm excited about this week's journey that we're looking at the basic science of bone and cartilage. One could argue these basic sciences are prerequisite knowledge that we have to have on which we formulate clinical decisions. It is these basic sciences that govern the decisions we make. When you think about making decisions, the prerequisite repertoire or pool of information we collect in our mind helps influence our intuitive decision-making as well as the scientific decision-making that is more quantitative than it is qualitative. When we look at the decision-making process of inductive reasoning and deductive reasoning, making decisions, again, I'd argue, is the most essential skill we can have as physical therapists. Again, we are the champions that must change the perception that physical therapy is the mere technical execution of intervention. But one could argue, as we have a unique body of knowledge at the doctoral level, it is the decisions we make, particularly with regard to what is limiting quality of life, what is limiting human function at the impairment level, towards the impairments that we really direct our interventions to. So to have an astute problem solver that has the capability of looking at data and discerning, making both deductive and inductive inferences to the decision-making process as to what are the impairments, and then prioritizing those impairments as we look at how they may regionally, interdependently influence human function and, of course, quality of life. It's these basic sciences in the vascular and peripheral and now bone and cartilage domains that are the fundamental essentials to human movement. And for that reason, they are prerequisite knowledge. That's why curriculum sequence, we have these early in the curriculum. And again, while we might not memorize minute details as we go through some of this study material, this material sinks into our cortex from which, when we make decisions down the road, it's these basic sciences that even go more basic than these sciences. They go to the level of physics and chemistry and biology sciences, the most basic of sciences, to where we make decisions that become somewhat automatic and it becomes logical as a result of understanding basic sciences. Yes, we'll get more involved later in the curriculum with current concepts of intervention and how we make decisions regarding those current concepts. But at this point, we're excited to go through these basic sciences that lay this prerequisite groundwork on which we will build our total pyramid of having a very stable foundation in the most basic of sciences. From a practical context, we got to tie this in to the rational nature of the field we've chosen, physical therapy. It's a field that, while it is sophisticated and complex, it is rational. When we make an explanation to a patient as to our plan of action, what we're going to do in the plan of care, after we examine the patient, we might explain that data and our exam findings to the patient and make logical sense of it to the patient. It is rational with our explanation based in these most basic of sciences. Most professions can't say that it is comprehensively as rational as physical therapy science is. To think that you're going to be a physician, say, and give a patient a beta blocker, try to explain how taking that small pill is going to affect the adrenal gland and the adrenal with the release of the hormones that would regulate blood pressure, adrenaline, and what have you. That is very complex and sophisticated biochemistry, which can be plausibly explained, but it goes well beyond what you could expect a patient to understand. On the other hand, with physical therapy, the fact that a patient might have acquired or a congenital curvature of their thoracic spine, let's say with a convexity to the right, causing protraction and elevation of the right scapula, giving weakness to the medial border stabilizers of the rhomboids and middle traps, and we end up getting a consequential hyperfiring of the upper trapezius, a glenohumeral anterior glide, tenderness of the biceps tendon. That whole complex, that symptom sign complex, can be with an audiovisual model, a skeleton, concisely explained to the patient to where they rationally understand these more macrobiological concepts rooted in these basic sciences of physics and biomechanics. So the ACE we have is the plausibility, the logical understanding governed by these basic sciences that make so much sense to patients and give them a rational role in participating. So that's not the reason most of us chose to go into physical therapy, but it's quite enlightening to wake up in 2014 and learn that you've chosen a field that does make rational sense if explained properly to the patient, and then they're a willing participant. It's these concepts that I believe help drive the fact that we as physical therapists will, by 2020 in particular, be deemed the practitioner of choice or the preferred practitioner, as stipulated in Vision 2020 from APPA. That consumers, with this being the information age, can look into making decisions and be more actively engaged with healthcare reform to take incentive, to take charge of making decisions about their own healthcare. And as a result, a rational science makes sense to them. And of course, it needs to immediately have some kind of dividends or results with regard to independent life, quality of life. So that being said, this lays the groundwork on which we are integrating these basic sciences somewhat as a prerequisite to our curriculum. So we turn our attention on this journey today. Our objectives are going to be to get through the material that describes best the basic sciences of bone and cartilage. And then we'll look at the implications from a rehabilitative context as we move from 14.2.3 ISC, basic science of bone and cartilage, into the applications via a rehabilitative context. We do have a wonderful opportunity also with a PowerPoint PowerPoint lecture that's going to be prepared by Dr. Chaz Barker and delivered today, which is going to work on integrating actually our vascular and peripheral nerve information with bone and cartilage, the synthesis and integration on which we will build now. We'll start with practical applications and contexts with which we can do that. So that'll take place at approximately 12:30, maybe 1:25 or 1:30. We will start with that PowerPoint presentation. So moving forward, let's go ahead and turn our attention to understanding some of the outcome measures that we need to satisfactorily complete, and that is starting with, as an orthopedic pre-OCS exam taker or a resident, needing to understand the role of chondrocytes, being responsive to mechanical stimuli. So I'd like to first address that to April. April, can you join us and speak to that, please?
Yes, can you go ahead and repeat the question there for me, please?
Sure, April. We're looking at our clinical applications of orthopedic basic sciences 14.2.3, basic science of bone and cartilage. And one of our first learner outcomes is going to be to understand that chondrocytes are responsive to mechanical stimuli. Can you comment on that? An example
Yes.
would be a variety of chemical factors. Go ahead into that, if you would.
Yeah, so I just want to make sure I answer the right question here. So yes, the reason that the chondrocytes can respond to mechanical stimuli is because there's connections between the chondrocytes and the extracellular matrix, which allow this communication to occur there.
Wonderful. Can you talk about what might happen with stress or injury to articular cartilage?
When there's increased stress that is placed upon an articular cartilage, it's able to produce an increased amount of prostaglandins, and also when this happens, it increases the rate of the matrix, which is then able to lay down more of that articular cartilage there.
Excellent, April. Well said. So we're talking about chemical factors that can be released by changes of stress or injury, or even altered load to articular cartilage can inhibit or stimulate matrix synthesis. So this is interesting. We have studies of increased and decreased use have demonstrated the alterations in chondrocyte metabolic rates and cartilage matrix composition. So load and stress, shall we say basic science of physics, is relevant. This discussion, April, fits well with my personal practice philosophy, which includes the use of orthotics. And an orthotic is about as basic of science as we can get. When we think about in Latin, what does the word orthopedic mean? This is a good question to jokingly work with an orthopedic surgeon. Ask them if they know. In Latin, what is orthopedic? What does orthopedic mean? And most are going to say something to do with bone, but that's actually osteo. Orthopedic, ortho being straight, pedic being child or foot. So it's straight child or foot. So if we look at straightness, now that we have these microsciences, chemical factors released in alteration to load, and all the changes that can happen at the matrix synthesis, etc., that type of now cellular biology is supported by this at one time the most basic practice of medicine. Prior to 1750, when Zacharias Janssen invented the microscope, prior to that, cellular biology was not known. And physicians prior to that time were often referred to as bone setters. And physicians practiced the most basic of sciences, i.e. Newton's laws, things like that. And they knew there was something to load and alteration and, shall we say, straightness, symmetry, and balance. And that was the state of medicine. Once cellular biology was found, i.e. the corks of a cell were found in 1750, and then of Louis Pasteur's work, of course, with the pathogen and microbiology, everything accelerated toward that direction, and the field of straight child, straight foot, was pretty much lost and left behind because of the all-encompassing challenge of understanding cellular biology. Until about 1890s, when osteopathy and chiropractic picked up. Those two fields came as a result of that actual initiative. So that being said, it's interesting that we see that there is a underlying microbiological nature to orthopedic, straight child, straight foot. Now, with evolution, it's kind of interesting that we've seen the field of orthopedics, which is almost always associated with orthopedic surgery in our culture. Yet one could argue the true straight child, straight foot, is a physical therapist. We're the ones that, if you go through our curriculum in residency, when you look at our biomechanical vital signs, our biomechanical staple, the information we're going to gather with regard to routinely gathering information that has to do with symmetry and balance, and these most basic of sciences that govern this. And now we have cellular biology to further drive this science, that we are truly the orthopedists when we think of it in that context. With the evolution of orthopedic surgical sciences, it's interesting that we see the surgeon become more of a technician who technically can do a very sophisticated technical skill to repair a torn ACL or debride a labrum. But the technical aspects of that are what really deems the orthopedic surgeon to be highly qualified and effective. So it's ironic that we moved as a physical therapist from being deemed like or considered as a technician with the physician ordering hot pack ultrasound massage circa 1960, that now we're critical thinkers and clinical problem solvers who use this biomechanical vital signs related to the sciences of straight orthopedic, straight foot, straight child, that we are really the critical problem solvers of this orthopedic domain, while the physician surgeon orthopedically has moved much more to become the technician part of that. So it's an interesting evolution that has occurred if we embrace this. However, certain models of practice, even today, will not let the physical therapists fully actualize this body of knowledge to their patients, that they are kept in a technical role. But as we evolve to become the primary neuromusculoskeletal provider that socialized medicine will require, that currently professional ball teams require, as we become that, we will see ourselves really actualize this most basic of sciences. Very good job, April. Heather Jennings. Heather, I'd like to ask you, could you address an understanding that chondrocyte activity varies based on the depth of the cells within the articular cartilage? Talk about the deeper cells, if you would.
Hi, Dr. Duvall.
Hi, Heather.
Hi. So are we talking about the 4 zones in the articular cartilage? Is that what you asked me?
Well, yes, we'll talk, deeper cells produce higher volumes of what? Let me help out a little bit. So the deeper, and then we'll go to the 4 zones, but the deeper cells produce higher volumes of protoglycans, DPGs, although the rate of matrix turnover there is slower. So we're looking at the deeper cells producing the higher volumes of protoglycans. Heather, stay on with me. How about understanding the types of collagen that make up the fibrous component of the extracellular matrix in articular cartilage? What type are they?
It's predominantly type 2 collagen. And then
Excellent.
There's other types, of course, as well.
Okay, excellent. Stay on with me, Heather, for a minute. Let's talk about understanding the function of the collagen network within articular cartilage. It's to resist what?
Tensile loading. Provide stability.
Exactly. Good. So yes, to resist secondary tensile loads caused by compressive forces and to limit the expansion of the articular cartilage from increased hydration. So this is very interesting stuff. Heather, stay on with me for one more. We need to understand that the protoglycans and the GAGs, GAGs, have a high ion concentration and understand its importance related to articular cartilage fluid phase. Can you just talk about that a little bit? What are they talking about here? The imbalance of drawing fluid and stuff. Can you address that?
Well, the result of a high ion concentration within the articular cartilage, I guess, creates a ionic balance. So it results in like swelling and a pressure gradient, so fluid is drawn in and out of the matrix.
Excellent, excellent. And specifically, the fluid movement creates tension on the collagen, which limits the volume to 20% of what would be obtained in free solution. So it's kind of an interesting osmotic pressure gradient change is what we talk about. How articular cartilage doesn't really have a blood supply artery going to it, but this pressure gradient change, which is load, unload, compression, decompression, which really and movement, of course, is what we're talking about, and how movement preserves the function of articular cartilage and how critical that movement is. And that this is relevant to what we might see working with patients with osteoarthritis. You know, we'll often see many joints that have become spondylitic. Let's take lower lumbar. You might see facet arthrosis, characterized with lateral views of facet hypertrophy, facet arthropathy. But that facet hypertrophy is nothing more than OA. And it's due to what? Compression. And at one time it was probably hypermobile, and due to that mobility and excess compression, it laid bone down a la kind of like Wolff's Law, or laid down additional osteophytic changes. And that makes it now hypo. So it's interesting how we might see joints that were hyper with time, as we age, become hypo. And this has to do with this process of what we're understanding that the protoglycans and the GAGs have on ion concentration, and how this really affects the articular cartilage fluid phases. Heather, thanks. Jessica, I'd like to turn the next question over to you. Can you identify the 4 zones that make up the articular cartilage? Jessica?
Okay, and Dr. Duvall, you said about to define the 4 zones, correct?
Yes, if you would.
Okay. So you have the superficial or the tangential zone, has the highest concentration of fibrils. And then the middle transitional zone, where the collagen fibers are more of a disorganized. Then the deep zone with the uncalcified cartilage, transitioning finally to the calcified cartilage zone, or the 4th zone.
Wonderful. Good job, Jessica. Let me ask you a question on which zone would the fibers be aligned parallel to the surface, producing a smooth surface for low friction gliding?
That's going to be the most superficial, or the superficial zone.
Well said. What level would have fibers that are perpendicular to the surface?
That's going to be the deep zone before your calcified cartilage zone.
Good. Although some of the fibers in the calcified cartilage are also perpendicular to the surface, but it's the deep zone. Well said. And then you already said the middle and transitional zone is going to be somewhat disorganized, and then the deeper zone fibers orient to resist. Well said. Okay. Jessica, while I have you, can we talk about understanding the stresses that can be placed on articular cartilage?
So it can be stressed with compressive loads as well as tensile loads.
Good. Yes, we're looking at compressive forces can exceed 10 times body weight. And contact areas are generally only several square centimeters. So contact areas are an interesting concept when we think of load and distribution and altering load. One could argue this makes plausible sense that we would do, say, a myofascial release before we actually did a roll, spin, or glide mobilization or manipulation, that the periphery of the joint could be influenced by length and tension of the extra-articular soft tissue, and that must be actually released prior to us doing a roll, spin, and glide, which then would alter, hopefully, the contact area, hopefully optimizing it to where the contact area would be where the cartilage is thickest and the cartilage is actually designed for that load. So all of a sudden, myofascial release, joint mobilization to where we could alter the length and tension of a capsule so that we can alter the contact area of the articulation, followed by permanent load distribution, such as an orthotic, where if you're using a rigid or semi-rigid orthotic, right away you're having a stimulus effect, a cause-effect alteration of where the contact area would be born. Now, another take-home point here, hopefully you would see this rational reasoning that to put an orthotic in, though, without addressing the myofascial length tension issues and the roll, spin, and glide issues probably would not be as optimal of using an orthotic, with ideally using myofascial release and roll, spin, and glide plus the orthotic to alter the contact area. So a little practical application. Great job, Jessica. Dr. McDonald, Kurt, can you help me with describing the biphasic and triphasic models that describe the mechanical properties of articular cartilage?
So articular cartilage is described as either biphasic or triphasic in the material. In the biphasic model, the two phases are solid phase, composed of the collagen and the proteoglycan matrix, and a fluid phase. And then in the triphasic, we add a phase, and that third phase is composed of charged ions within the matrix.
Well said. And Dr. McDonald, can you help us with describing the characteristic behavior of articular cartilage under compressive load?
In discussing the articular cartilage, the mechanical characteristics result from an interaction between the extracellular matrix, the charged particles, as we talked about before with the ions, and water. So as the compressive forces are applied, there's a tendency for a fluid movement to be created kind of across that membrane. And due to the small pore size, frictional drag forces acting acting against the fluid movement which are large and fluid component of the matrix, they actually load, and that protects or shields the solid component. And as we're talking about articular cartilage, we know that it is load dependent. So as that compressive force increases, the solid matrix reduces the pore sizes with that pressure, and that decreases the permeability, that increases the frictional drag forces, and causes the proteoglycan charge density to increase, which further decreases the permeability. And at some point in time, when there's enough compression, we get to an equilibrium, and when that equilibrium is reached, that equilibrium between the applied forces and the frictional drag forces, there's no longer a fluid movement across the membrane.
Kurt, that was perfect. Now, what is it called? A coefficient of friction. I know that's not actually in this ISC, but could you maybe integrate how the coefficient of friction would be applied here? Concepts of physics.
So coefficient of friction, that is the amount of force taken to get something to start moving. I'm going to give you an example. Like during the FCE, we have a sled, and the person has to get that sled to slide. Well, it takes a significant amount of force to get it moving, but once it gets moving, it's a lot less. So for a 50-pound sled, the person may have to create about 150 pounds of force, but once it gets going, it's only about 40 pounds to kind of keep it moving. So it's the same kind of thing here. We have a certain amount of force that has to be applied to get that fluid to go across. But when we get to a certain point where we put too much force, then we have equilibrium and we no longer get any fluid going across.
Outstanding. Great job. Yeah, so small pore size with frictional drag forces are large, limiting fluid movement and leading to the fluid component accepting most of the compressive load, protecting and shielding the solid component. So it ties right in. So well done there. Thank you. Okay, let's turn over to Matt Zanis. Matt, welcome on board. Great to have you with us. Can you talk a little bit about how the resident can describe the biomechanical properties that apply to articular cartilage? The biomechanical properties, such as viscoelastic, etc.
Dr. Duvall?
Yes, you sound great.
Can you hear me? Yes, good, perfect. All right, the viscoelastic properties of the articular cartilage are important because we could end up stressing them too much by putting too much pressure on them. That could actually cause them to degrade and lose fluid and whatnot. So the constant stress, they'll undergo creep and then actually deform farther than we actually want them to. This, in turn, will actually redistribute the fluid around the matrix and the contact area of the joint. And if it's gone too long, like past the initial loading, the phase only supports 90% load. So you could, in turn, actually do too much work and cause that tissue to deform too much. So you have to find that perfect area of treatment that you can stress the tissue enough that you get a desired effect, but then not stress it too much that you can actually cause damage.
Matt, that's excellent. So when we look at this viscoelastic material, and it's actually time dependent. Under constant stress, the tissue undergoes creep and stress relaxation. During creep, the load is gradually transferred from the fluid phase to the solid phase. And then during stress relaxation, like you say, there's a redistribution of fluid. The fluid phase supports 90% of the load and can be maintained for approximately 15 minutes. Full transfer from fluid phase to solid phase takes about 2.5 to 6 hours. So it does take time. Got to remember, too, fluid doesn't compress usually. And the lack of compressive ability of fluid sometimes is a variable here that we have to take into consideration. Matt, great work. Natalie Cook, welcome on board, Natalie. I'd like to direct your attention to asking about how you can demonstrate understanding of the nutritional as well as the waste removal systems from articular cartilage and attempts to enhance these symptoms by utilizing reciprocal loading and unloading techniques in treatment. So can you address that for us, Natalie?
Can you hear me?
Sounds perfect, Natalie. You're on.
Okay, great. Well, since articular cartilage doesn't get good vascular supply or nutrients, it has to get it often from the synovium, the synovial fluid. With the different osmotic, I'm going to try not to get too technical. I was a chemistry major undergrad, so with the osmotic pressure changes, the fluid will fluctuate depending on what kind of proteoglycan, what kind of molecules are within that space, and that fluctuation can bring in nutrients or release nutrients depending on what the matrix is compromised of. Does that make sense?
Natalie, that's great. So we're looking at utilizing controlled intensity of the CKC activities or contraction of muscles on the open kinetic chain activities to load and unload joints when indicated. That would be the practical application. So again, controlling the intensity of closed kinetic chain and or a co-contraction of muscles in the open kinetic chain. Good job. Moving on, Ryan. Welcome on board, Ryan. Can you help us with understanding the effects of immobilization on articular cartilage? Gotcha, Ryan. We'll move on. Hang tight. See what you can work out. You can call in. That'll be fine. I want to address a question, though. Can we, and Tom brings up a great question from Lycoming Physical Therapy, and, would we expect OA changes with hypomobility? Well, due to the effects of gravity, unless we live on a space station or are in an aquatic environment where there's obviously a decompressive unloading of joints, there's going to be with normal mobility. Let's start back by saying every joint in the human body is either going to be hypermobile, normal mobile, or hypomobile. And in our on-site courses, we look at the reliability of studies to discern that. Is this joint that you're feeling hypermobile, normal, or hypomobile? One could argue every joint is one of those three choices. Now, interrater and intrarater reliability is a big question. The interrater reliability is poor for most activities where we discern the mobility. We accept that in the modern manual therapy world, that reliability between practitioners is not going to be as high as what we'd like it to be. For instance, assessing elbow extension and feel of it being hypomobile, hypermobile, or normal has a pretty good interrater reliability. But flexion of the elbow, pretty poor interrater reliability. We're going to look at the metrics of some of that when we actually do our on-site courses. And then we could come up with a proposed grading scale that normal mobility of a joint would be considered a grade 3. Hypomobilities would be a 2, 1, and a 0 being ankylosed, bony end feel, no movement. And on the other end of the spectrum, a 4, 5, and 6 would be degrees of hypermobility, with total instability being a 6, necessitating, of course, some form of stabilization with open reduction or what have you. So we'll look at a grading scale, but our reliability is not always the best. But it's better than having no attempt to grade mobility. So we're going to attempt theoretical-based practice to have some quantitative method to determine mobility. The question at that point would be, can we expect some osteophytic changes with hypomobility? And I think we see the answer to that being yes, because now you're looking at it exponentially increasing with osteophytic changes due to the compressile loads. With hypermobility, there's excessive movement that stimulates the laydown of osteophytic changes, which is an attempt naturally to stabilize the joint. But it doesn't stay there usually. Then we get on the other side of the spectrum with hypomobility, and then it accelerates the laydown of this exostosis, this development of bony stabilizing via Wolff's Law that makes it exponentially accelerate. So I think it's interesting as we get older, years actually get shorter, i.e. the degenerative process is accelerated versus the micro changes that minimally occur in the first 4 decades of life, and then we see an acceleration after that. So yes, changes would occur with hypomobility, and arguably even more so moving toward finally some form of ankylosing or some form of huge amount of exostosis. Okay, Ryan, you're on the phone now. Let's take a look at understanding the effects of immobilization on articular cartilage, which is kind of answering Tom's question, can we expect OA changes with hypomobility? Go ahead, Ryan.
Okay. Well, first I'll start off by saying that the degree to the extent of these changes depends on whether the immobilization is rigid or less rigid. So just to keep that in mind. And then several changes in articular cartilage as a result of immobilization. There's decreased thickness in the total and non-calcified cartilage, increased thickness of the calcified layer, irregularities in fissuring. The extracellular matrix, you also have decreased proteoglycans and building of the proteoglycans and decreased aggregation or them accumulating together, decreased gags in the superficial regions, reduced cross-links, more water in the extracellular matrix, decreased cellularity of the chondrocytes, and you also can get decreased synovial fluid or synovial levels of the TNF-alpha and interleukin-1, and also the elastic modules and compression and shear. You get some tissue softening in there.
Ryan, that was outstanding. Great job. So I really like where you alluded to the amount of rigidity of the immobilizing device as being relevant. And I think also directional specificity of that immobilizing device. Is it altering load? One could say a semi-rigid or rigid orthotic would alter load due to gravity and close kinetic chain. And where we're distributing that load becomes relevant to this equation also. An interesting concept. Great job, Ryan. Spencer, Dr. Wingate, can we go ahead and look, Dr. Wingate, at understanding the effects of remobilization following immobilization on articular cartilage? So we're looking here at the effect of remobilization following immobilization on articular cartilage.
Your line is now unmuted.
Yes, Dr. Duvall. The period of remobilization does not result into full restoration. And what they found was that the PG, GAG, and the cell numbers, they have reported to remain below values. This was following 15 to 50 weeks of remobilization after 6 to 11 weeks of immobilization. But they also mentioned that in contrast to most reports using longer periods of immobilization, 2 weeks of remobilization following just 4 weeks of immobilization were sufficient to reverse the PG staining changes.
Dr. Wingate, that's outstanding. Great explanation. So the take-home point here practically sounds like we've got to be careful not to immobilize. That the consequence is dear in that remobilization does not fully restore the cartilage matrix, even after 50 weeks. So to immobilize becomes a very interesting, convoluted process that is difficult to undo. And immobilization, sometimes the pros outweigh the cons, but this unfortunate insidious onset of cartilage degradation is tough to track. It would be easy to make a quick decision to immobilize someone, kind of like defensive medicine. You know, when in doubt, just immobilize it, which I know historically a lot of traditional general practitioners used to do when they did sports medicine coverage. And they could never be held accountable that the consequence of that immobilization might be 20 years later in that individual's life, to where the degradation of the articular cartilage then presents itself. Follow me. The insidious onset of the cartilage degradation is hard to track back to the decision some practitioner made some 10, 15, or 20 years ago. But understanding this basic science is what is unique to us to help make these decisions more prudent, more wise, knowing the long-term consequences that we understand as physical therapists. And again, ideally situating us to be this primary neuromusculoskeletal decision maker with regard to mobilization and immobilization. Another relevant concept here is for us to think about, as we are physical therapists, many in here with many years experience, some of us relatively new to the profession. But I would argue, in my 30 years experience, probably the number one impairment that I have seen over my career is hypomobility. Hypomobility. Yes, I've worked with many patients with instability and hypermobilities, but usually there is a hypomobility in the vicinity that is facilitating another area to become hypermobile, be it axially in the spine or be it in the peripheral joints. But yes, it's interconnected, it's interdependent, and there's usually a hypomobility driving the hypermobility. That's why it's hyper, because some other segment somewhere is hypo. So I would argue our ability to have skill sets to treat hypomobility, if it's probably going to be the number one impairment we see throughout our career. Looking at the work of Dr. Josh Cleland, he wrote a paper that was presented at the American Academy of Orthopedic Manual Therapists 2 years ago, and it was quite eloquently discussed. The title was, "If Manual Therapy Works and is so popular with evidence, why isn't everybody doing it? Why do we see the majority of physical therapists not assess a joint to be hyper or hypomobile at the articular level, at the arthrokinematic level? Why would we not look at that routinely to get the prerequisite joint mobility in place if it's restorative? If we have skill sets that enable us to make a joint that is hypomobile move better, i.e. simple basic sciences of stress-strain. Just look at the stress-strain curve. If we go to the barrier, then work plastically on the other side of the barrier, we will make a change in that joint's mobility to then reset the muscle spindle for that newly acquired mobility and then put that into something functional that is uncompensated integration into function, non-substituted, and then move into therapeutic exercise. I would argue our professional colleagues probably won't adopt this model of practice philosophy until we what? Until we shift for a performance-based reimbursement model. The minute that your outcome, i.e. a functional outcome related to independent quality of life, is deemed worthy of reimbursement, will all PTs going to practice what they were taught in school? That a joint's mobility is relevant, and be it hyper or hypo, to probably find your career treating more hypos, and then neuromuscular rehab, then functional training, then therapeutic exercise. We'll spend more time on this later, but At this point of the discussion, a joint's mobility prerequisitely makes sense that we examine that, evaluate it, and put together a plan of care with evidence-based interventions using basic sciences of stress strain to restore that joint's mobility prior to doing mere therapeutic exercise, where they're built in compensations, substitutions that will later result in a readmission of an unresolved impairment. Dr. McDonald, would you like to add to that discussion?
Yes, please. One of the factors we talked about earlier, in addition to the rigidity of the immobilization, would be the age of the subject. What we're seeing right now is I'm getting a lot of veterans that are retiring. What they're doing now is before they retire, they make sure they get all their surgeries. Well, we're getting a whole lot of meniscus repairs in our soldiers, and they're coming back with prolonged immobilization protocols that they're using right now for some of the military guys. And what we're finding is, like it says here in the ISC, vigorous exercise immediately following immobilization may actually lead to more tissue degeneration. So, patient comes in and we can't do very much but open chain exercises, right after immobilization, or even during the immobilization when we get them. They may have 2 to 4 weeks left in their immobilization when we get to them. So we have to, at that point in time, find out or really start searching where else is there hypomobility. And we start looking at those regionally interdependent things. So we start going to the ankle and going to the hips. And, it's been 100%, we're batting 100 here, that we're going to find something, whether it's in the lower back, the hip, or the ankle, as far as hypomobility. And, you have a service to your patient. During that 2 to 4 weeks of immobilization, where you can only do so much, you're looking at mostly open chain exercises. We have to find those other structures so that when we do get to a point of closed chain and we do start working against gravity, that we've taken care of what it was that caused the meniscus issue in the first place. And a lot of times for these individuals, it's not a one traumatic event. It's usually a cumulative trauma, and it's usually something where the body is broken down over time. And that's what the soldiers have done: repetitive trauma broken down over time. So they have, ridiculously tight hips, ridiculously, pronation situations going on with the ankle. So that's the beauty of this ISC, taking a look at certain things and realizing that as tissue heals, we have a fiduciary responsibility to the patient to go after the other areas that are also involved in the pain and the problem.
Excellent discussion. Thanks for bringing that in. And I think Dr. McDonald alludes to a couple unique points. One is that this is a unique body of knowledge. These basic sciences are universal sciences. I mean, if you believe this literature and it's peer-reviewed and published, and we take this to be somewhat true, what we're studying here, that it's science, then we have some moral duty to take this and advocate with it, that societal needs, and we see certain models of practice that don't hold high regard for some of these basic scientific truths. And we have got to champion that. For if we remain in a 100% referral-based model that stymies our freedom of speech to advocate with this information and knowledge without retribution from a referral source, that's one of the biggest ethical dilemmas that we have in our profession. So we believe these sciences to be evident and true, and then we have to have the freedom to advocate without retribution on a more parallel discussion than a subordinated discussion that has historically been our role. This is why there is a DPT, this science, having a terminal degree authority to represent it. And yes, it is relevant to major issues, function and quality of life. So thank you. I'd like to jump over to Tom out at Lycoming Physical Therapy. Tom, we're looking at understanding the differences between primary and secondary osteoarthritis. Could you tell us a little bit about the differences between primary and secondary OA?
guess primary OA would be described as an idiopathic condition without a precipitating factor. The other variety would be a secondary OA that may have a known underlying cause, which may include a prior injury that would have altered joint mechanics and ended up in asymmetrical loading of a particular joint compartment. For instance, the tibiofemoral joint. If you create laxity in the knee with an ACL injury or perhaps one of the collateral ligaments, you can asymmetrically load a knee in that regard, and you can wear out either the medial or lateral tibiofemoral compartments prematurely by altering the biomechanics in that regard, and so leading to degenerative changes that would be, I guess, realized. I think one of the studies or one of the readings, it indicated that after an ACL injury, I think they anticipated it was about a year that they may begin to notice degenerative changes occurring within the joint. Actually, long before, at times, you'd expect a sympathetic or long before the patient may begin to notice some symptoms. There may be evidence of degenerative changes that might occur, if I'm correct.
Okay, Tom, thanks. Tom, excellent job. And let me also describe some common changes to articular cartilage during the development of OA. You see the early phase being an increase in synthesis and turnover of cartilage matrix components. And then we also see over time degradation exceeds the synthesis. And then there's a decrease in proteoglycans. And then there's increase in water content, almost universally reported, allowing greater swelling of tissue due to a decrease in the proteoglycans. And the collagen network is less orderly and turnover increases. So these are the changes of articular cartilage during the development of OA. Then also we want to talk about understanding advanced age and how it plays a role, like Dr. McDonald alluded to. Advanced age is a strong risk factor for primary OA. Age cells are less able to mount and maintain a reparative response and are less responsive to anabolic influences of mechanical and chemical stimuli. And yes, anabolism, anabolic, just means tissue building. So now we want to look at understanding the use of immobilization in situations where articular cartilage is damaged. And so some of the concepts we have to appreciate is the degree to which the repair is successful appears to depend on the extent of damage and the nature of activity following the damage. The environment becomes relevant. We're now leading into discussions that have something to do somewhat with stem cell, to where we believe the environment has to be conducive for some of the repairs and regeneration, even stem cell biology as we look at that we will have a role as physical therapists in making environments conducive for success. An example might be decompressing the joint load by doing capsular distraction. Might provide an environment that's more conducive for a repair or even stem cell injection. We also look at when the articular cartilage remains intact, at least partial repair or regeneration should occur following the immobilization. And then understanding the chance of repair where the articular cartilage is not intact is limited unless vascularity from the subchondral bone has been invaded. It's where we see K-wires and what have you often used to stimulate that subchondral bone, which would hopefully facilitate some vascular effect for which the repair could occur better. So vascularity is relevant. Remember, ironically, the periphery of the knee meniscus, the periphery of the meniscus is more vascularized than the core central part. So repairs sometimes can occur there better. We also in this lesson have to describe factors that shift the balance between reabsorption of bone and production of bone toward reabsorption. Of course, age, estrogen, disuse, and other disease processes can be a factor that shifts the balance between reabsorption and bone. Now we also have to look at describing the makeup of bone. Well, we have osteoblasts, the bone-forming cells, and then you have osteoclasts, which are going to be the bone reabsorption cells. And then you're looking at the ECM, inorganic component, and then you have the ECM organic component, type 1 collagen providing tensile strength, and a site of mineral depositing. We want to look at describing the morphological makeup of the various classifications of bone. Short bone, you have your thin cell of cortical bone surrounding callus bone filling the interior. You got long bone, the diaphysis, is predominantly cortical bone, while the metaphysis has a thin shell of cortical bone with callus bone in the interior. Flat bone is the plate of cortical bone surrounding the central region of the cancellous bone. Now we have to describe the microscopic morphology of bone. So here we're looking at the bone is classified as either woven or laminar based on the organization of the cells and the ECM. The long bone has a system of osteons and the Haverson canals that run longitudinally, with the Volkmann canals that run more horizontally that contain blood. They also contain lymph vessels and might even contain some nerves and least connective tissues, from which we also often get an osteotome representation, i.e. we have dermatomes, myotomes, and osteotomes. So we also need to identify the importance of the periosteum, and it covers most of the outer surface of bone. There are two layers. A dense connective tissue makes up the outer layer, while the inner layer contains bone lining cells along with osteoblasts and the vascular system. It serves as an attachment site for tendons and ligaments. Think of putting a tent stake in the ground. It is interfaced in the retinacular connections of tendons and ligaments is woven through the periosteum. Of course, immediately comes to mind the stress fracture and the innervation of periosteum and how it's susceptible to vibration. We need to understand that bone is highly vascular. An elaborate network ensures that all cells are within approximately 300 micrometers of a blood vessel. Long bones have three systems of arteries known as the medullary arterial system, and then it improves the ability to heal. Of course, the fastest healing bone in the body is the clavicle due to its vascularity and its proximity to the blood-rich thorax and the heart, and the least vascular bone in the body being the navicular, where interestingly the blood supply for the navicular comes from distal to proximal. The scaphoid in the hand is what I'm referring to, where it's a kidney bean shape, and the distal pole is where the artery attaches to that bone. So the resident identifies bones at risk for avascular necrosis post-fracture due to limited vascular canals. Talus, the only bone in the body that has no muscular attachments. the femoral head, and the scaphoid. Femoral head and the scaphoid and the talus. Risk for avascular necrosis. So identifying factors that increase risk for fracture, mechanical properties along the loading characteristics determine the risk of fracture. Aging changes, demineralization, balance, muscle function, and characteristics, of course, of a fall. We also have to understand the loading patterns of long bones, the strength of bones to the loading patterns, and variation between immature bone and mature bone. Of course, during daily activities, long bones are subjected to complex loading patterns that include both bending and torsion. Bending creates a compressive load on the concave surface and a tensile strength on the convex surface. This is considered to be called a piezoelectric effect. You might want to look that up and just do a little cross-referencing on the physics involving piezoelectric effect. That's P-I-Z-O, piezoelectric effect, where the concavity lines up the negative ions and the convexity, the positive, and etc. You might want to take a look at that. It has a lot to do with the laying down of minerals. Torsion creates complex combinations of compressive, tensile, and shear stresses. Muscle contractions alter distribution of these stresses, often opposing the external load. Now, cortical bone demonstrates the greatest strength and stiffness when loaded parallel to the long axis and more brittle when loaded perpendicular. Adult bone will fracture first to tensile forces, and immature bone may fail first with compressive forces. So, I want to jump toward the rear of this ISC and just briefly address identifying typical pharmacological interventions for osteoporosis. And these interventions focus on either inhibiting bone reabsorption or accelerating bone formation, or both. Bone reabsorption inhibitors, estrogen, progesterone, selective estrogen receptor modulators, calcitonin, and a lot of this is mediated by what organ? The thyroid. The thyroid, which we'll do in medical screening classes, we definitely want to inspect the thyroid. But these hormone balances and regulation of the biochemistry, particularly blood calcitonin levels, are stipulated by the thyroid gland. Thyroid stimulating hormone. So bone formation is intermittent parathyroid hormone therapy, most common. So inspection of the thyroid or a history of thyroid has something to do. And this all be with bone density. And this all has relevance, of course, to us being manual physical therapists who are looking to consider bone density as a prerequisite medical screening criterion, i.e. we look at medical screening hypotheses viscerally, we look at them psychosocially, and then we look at orthopedic medical. Bone density becomes more and more relevant as we become manual therapists who do mobilization and manipulation, where bone density becomes relevant. Okay, without further ado, let's jump over to ISC 1424. We've got about 12 to 15 minutes before we jump into our PowerPoint Practical Integration and Synthesis Complex section. April, I'd like to jump over to April. April, if you can help us with 1424, where we're looking at consideration for rehabilitation. Can you help us with identifying signs of excessive loading or overtraining when examining patients? Special emphasis on young patients with immature bone in regard to the muscle-tendon interface and the epiphyseal plates. Can you help us with that, April?
Hello? When
Sounds
you are
perfect,
examining,
April.
when you are examining young adults or adolescents and you're concerned with overtraining or excessive loading, especially at that muscle tendon bone interface, some of the signs that you will see would be tenderness of palpation, swelling, or even a palpable bone deformity are common to see at those subphyseal plates.
Excellent. So pain out of proportion with exercise or activity, reduction in performance without specific injury, got to rule out non-musculoskeletal causes, young patients with immature bone and proper technique with weightlifting. Then we have tenderness to palpation, swelling, hyperemia, and a palpable bony deformity. As we look at really orthopedic medical screening, some of these would be subjective findings, and a few of these, of course, palpation, swelling, hyperemia, and the palpation of bony deformity would be physical exam medical screening for orthopedic medical. Excellent. Heather Jennings, can you help us with monitoring and modification of functional activity of the youth patient at high risk for tendon avulsion? Heather, can you open your microphone for us and address how the resident would monitor or modify functional activity for youth patient at high risk for tendon avulsion? Jessica, let's jump on down to yourself. Can you address that for us, Jessica, please?
So definitely some symptoms that you may see with a muscle tendon bone insertion injury, especially in a young adolescent. It's going to be reproduced with active contraction or resisted contraction of the involved muscle, as well as passive stretching of the involved muscle and tendon. So definitely, if you see any of those signs, you definitely want to refer out. And as far as, modification of activity, with those young adolescents, is you want to kind of stick with the more light to moderate levels of loading in those individuals, as well as avoiding, that overtraining and making sure that they're progressing safely through their exercise program.
Yes, that's excellent. Matt Vanis, can you jump in here and talk about sagittal plane versus frontal plane activities, perhaps, that you'd want to modify?
Can you hear me, Dr. Duvall?
Sounds good, Matt.
Okay. As far as sagittal or frontal plane activities, you would just want to decrease the amount of stress that we place on end ranges of motion with the tendon insertions in these young athletes.
Excellent. Can you give us an example of some sagittal plane versus frontal plane?
Sure. Sagittal plane activity could be something like a front lunge. A frontal plane activity could be something as like a rear belt raise or a hip abduction exercise.
Yeah, jumping or cutting sports usually are going to fit a little more frontal plane, but excellent on that discussion. So we're looking at demonstrating awareness of the incidence of epiphyseal growth plate injuries, and 15 to 30% of skeletal injuries in children are in this epiphyseal area. This discussion's got to be relevant to torsion, rotary forces, that can occur particularly with ground reaction forces when there's an excessive amount of either forefoot or rear foot biomechanical anomalies, a forefoot varus with calcaneal valgus. Let's say we're seeing a lot of excessive pronation. And the torsion that would go superior in a closed kinetic chain through the tibial epiphysis. And that often results in a shearing stress, and the body's, that's a hypermobility, so the body's reaction is exostosis to reinforce it via Wolff's Law, and we get Auschwitz-Schlatter as a result. But I want to make sure we're aware at the epiphysis that we think about torsional forces, rotary forces, not only length tension forces. Length tension forces often occur with growing, i.e. a growth pain, i.e. someone's bone development, growth occurs there, and the muscle is forced to adapt to the new length of the bone. Genetically, the bone grows from the epiphysis, but the muscle is forced to accommodate the new length of the bone. And this is another reason that one would argue that every adolescent and adult probably should have their own physical therapist, just like they have a dentist, because there's constant dynamic adaptation to our environment, growth changes, aging changes related to impairment as related to function and quality of life. So one could argue that we should have a routine biomechanical vital signs staple type exam on growth and development and then aging individuals also, kind of like a dentist would maintain dental hygiene and dental integrity. We need to do movement integrity. This incidence of 15 to 30% of all skeletal injuries in children have to do with the growth plate. Okay, we want to also look at designing exercise programs for children and adolescents that will allow them to obtain benefits without placing them at risk. Matt Zanis, can you address that? Designing exercise programs for children and adolescents.
Sure. Designing exercise programs for children, you want to focus on a variety of functional tasks, anything from light to moderate strength training and making sure they have proper form with each movement before increasing weight. But then you also want to worry about their aerobic conditioning just for general health benefits. As far as the adults go, you could start progressing them with more advanced type of training as long as their fundamental movements are approved by you as the physical therapist, so they can avoid these type of overuse and overstraining type injuries.
Excellent, Matt. So we're going to avoid the use of any overtraining, of course. So we got to remember that using physical activity can be used as a simple screen for malalignment. That if someone gets symptoms without a significant load of overtraining, then one could argue it's malalignment. But properly aligned, we're still going to have a threshold to where there would be symptoms. So this is something to keep in mind with regard to the volume of training. At the same time, hypotraining, less than ideal movement, we could argue that the integrity of the neuromusculoskeletal system would not be promoted to its fullest attributes during this all-important growth phase, growing times of adolescence, to where the collagen would receive its maximum stimulus for proper alignment of the cartilage and of the actual collagen laydown. Well done, Matt. Thank you. Okay, moving on, Natalie Cook. Let's take a look here, Dr. Cook, at identifying the most common mechanisms of injuries in the upper and lower extremity of adolescents. What's the most common?
Can you hear me?
Yes, you're good.
Probably one of the most, any kind of torsional, torque type injury, especially on the knees, is what I've been seeing. And then any kind of excessive weight bearing, as far as like with gymnasts, constantly having that repetitive force into their upper extremities, back handsprings and different activities. So probably compression and any kind of torsional torque force.
Well said. And this brings in a rationale for our biomechanical staple, which some of you have not been introduced to yet, but it's exhaustive methodology where we would argue in our curriculum that there are biomechanical vital signs that we should gather data related to function on every patient, prerequisitely. And these are at the impairment level, not at the functional level. So we're going to try to find positional faults that we see that could predispose someone to an injury. For instance, we would note genu valgum, genu verum, genu recurvatum, any kind of alignment issue that later, if we looked for a regionally interdependent reason that another area is in symptomatic pain or dysfunction, that this could be a contributing factor. So the screening of these variables is relevant for identifying what someone would be predisposed for. One could argue that a Beighton score is in that category also. If someone has systemic benign hypermobility, a high Beighton score, needless to say, their joints probably don't have as much secondary stabilizing capacity as someone who is in more of a normal Beighton range. So these factors all affect our clinical decision making. Okay, we're getting ready to turn to our PowerPoint. Before we do that, I'd like to turn over to Dr. McDonald. If he could wrap up for us this section 14.2.4, considerations for rehabilitation with regard to bone and cartilage. Without going through all these elements, Dr. McDonald, can you give us a summary of what we need to appreciate from the remaining portions of this ISC? And in, say, 3 minutes or so. Can you wrap this up for us, please?
In regards to dealing with our adolescent or teenage and even the younger kids, we have to realize that a lot of what's going on in sports right now is poor training. I'll give you an example. Would be for a basketball girl, learn the ability to learn how to jump and land. We start talking about reducing some of the forces. Just kind of a clinical pearl. As we're teaching jump training for girls, we'll actually have them jump from the side of the pool into the pool, and we'll actually record how they land, and we'll teach their parents how to kind of critique that. So as we're talking about reducing some of the forces and avoiding overtraining, it's giving them other methods of training. So using the pool to limit the gravity or the ground reaction forces on them. For some of our gymnasts, when we take a look at gymnastics injuries and cheerleading injuries in our young female athletes, we'll see that a typical cheerleading routine lasts 3 to 4 minutes when they're competing. And if you take a look at when injury happens, most of the time the injuries happen about 2 minutes and 20 seconds to 2 minutes and 40 seconds into the routine. And why is that? It's poor aerobic conditioning. So as we take a look at things, we have to take a look at a global perspective and not just this is an ankle injury. We have to take a look at how did the injury happen, when did the injury happen, what activity. Was this person a flyer, was this person a spotter, and take a look at their position. With our baseball athletes, we start taking a look at some of the young kids and they're overtraining with throwing and they're developing and elbow injuries. And we start learning ways to not only strengthen things off as far as how much, and educate not only the coach but educating the parent as to what should a child be doing. Looking at return to activity also, we have to take a look at how long does it take the child to heal. Are they fast healers? Are they slow healers? And we know that kids bounce back pretty quickly, but they don't necessarily have the ability to tell you everything you need subjectively. That's why we have to take a look at more objective data, which would be going back to the swelling, the tenderness, the palpation, the palpable bone deformation, looking at those things because we need to see, is this person developing osteoporosis? Is this person developing some form of bony malformation that we can prevent by slowing things down and by changing not only the throwing mechanics, but also changing whether they're throwing or not.
Excellent. Let me ask you, if you would, as we look at a different population a little bit there, one last discussion. Could you throw in the considerations for osteoporosis for me, Dr. McDonald, as related to orthopedic manual therapy?
Podcast is brought to you by Doc. When discussing osteoporosis, we have to take a look at what are the things that we're going to do with manual therapy, whether we're going to do a joint mobilization or something like that. We take a look at a couple of things. Looking at the biomechanical staples, we take a look at the Beighton score. Is this person typically a hypo or hypermobile? That kind of lets you know, kind of helps you with your discussion. Looking at your medical screening, we're looking at does this person have a history of cancer? So we take a look at multiple factors when we take a look at our osteoporotic individuals. But we have to do no further harm as far as treatment. So as we start taking a look at mobilizing an osteoporotic joint, we go, is this person indicated? So looking at all the intrinsic and extrinsic factors before we actually lay hands on a person. Because are we going to mobilize a hypomobile joint, or are we mobilizing a hypermobile joint that has other situations going on? So sometimes it's doing a thorough evaluation of the joint above and joint below to realize where you should actually put your hand and what you should be mobilizing.
Well said. Thanks for adding that. And I'd like to argue one of the research characteristics of clinical mastery, of expert practice, is that the expert and arguably the board certified physical therapist is going to take prudent risk, that they would mobilize somebody if it's indicated of value that the novice physical therapist would not mobilize. They would be willing to take prudent risk. So traditionally, osteoporosis has been deemed a contraindication to manual therapy mobilization. But I would argue it's probably based on the basic sciences we looked at with bone and cartilage, with load, compressive forces, decompressive forces, altering load. It probably is one of the most effective interventions if we can intervene and implement that with minimal risk for fracture. So my summary remarks would be that distractive type unloading of a joint to enable redistribution of forces to the more compact bone and to promote mineral uptake probably is indicated. And we'll talk about that on our on-site courses some, the integration of this material further, and how with osteoporosis, you as a master clinician will use manual therapy on patients with osteopenia and osteoporosis in a very prudent manner that will result in a better outcome than if it was not implemented. So without further ado, I'd like to turn the home screen over to Dr. Chaz Barker, a evolving fellow in training, to present his PowerPoint to integrate and synthesize both the vascular and neurologic components with bone and cartilage. Dr. Barker, you can go ahead and put your PowerPoint up.
Okay. Hello, how's everybody doing today? Can you hear me?
Your microphone might be a little bit too close to your lips, getting a little back.
Okay. Is that any better?
That's better. That's
okay.
Better. You don't have to talk so loud.
Gotcha.
Hey, Dr. Barker, this is Dr. Brent. Just let me know if you have any technical difficulties or need help getting set up here, okay?
Okay, sorry about that. I think I got kicked out.
Your audio's good now.
Okay.
Okay, Dr. Barker, I'm promoting you right now.
Gotcha, now I see it. Okay.
Off the share. Yep, and share your PowerPoint.
Thanks.
You got it.
Okay. Can everybody see that?
Looks great.
Okay, at any point, if you can't hear me, just let me know, or if I'm talking too loud or too soft, just let me know, and I'll try to change that. Guys and gals, welcome to this ISC, and I just appreciate Dr. Duval and Dr. Brenson Brzezinski, extending this invitation to me. And so what I'm going to try to do is, if any of you've read through I'm assuming everybody did read through the ISCs. It's definitely some technicalities in there, some great things for us, and I think the ISC does a great job at explaining that. And so I think as residents and hopefully eventually fellows, what our goal would be is that we can take this information and, you're going to become orthopedic clinical specialists, not research specialists. So our goal should be to be able to take this information to the clinic, and apply it to our patients and get better outcomes for them with the best evidence out there. So I had shared this story with Dr. Duval. It was a story that came from the Journal for the Academy of PAs, of physician assistants. And it talked about a case of leg erythema. So I'm going to share that with you. And then he asked me to try to kind of theoretically tie that into some of the concepts that you're learning this week with bone. So we're going to do that today. So simply, I'm just going to present a case study. I'm going to discuss practical implications for treatment. And then hopefully I'll have maybe a couple of minutes that we can answer any questions if anybody has any. So here's our case. We have Dr. Gregory House, I think it is. He's a 41-year-old man presented to a medical clinic with a fever of 101.8. His chief complaint was that he had left lower extremity pain and erythema. And the referral from his primary care was possible cellulitis with knee joint infection. And as we're going through this, I want you to think about the fact that if you get direct access patients, this might be a patient that comes to your clinic, and maybe the referral would just say treat for knee pain, knee and thigh pain. Okay, so the subjective is he had 3 days of bilateral lower extremity pain with upper thigh erythema, no swelling. He had associated knee pain that lasted for 3 days. His pain was a 9 out of 10 on a verbal pain scale. His pain was not relieved with acetaminophen or any anti-inflammatories. He said he was recently scratched by a rooster on his farm, but the skin was still intact. He denied numbness or weakness of the lower extremities, and he did have some minor cold symptoms, but he didn't have a history of recent trauma, surgery, hospitalization, chest pain, shortness of breath, hemoptysis. He had recent unintentional weight loss of about 30 pounds in 3 months, which seems like quite a bit. And he had a few episodes of non-bloody diarrhea. In his past medical history, it was unremarkable for any kind of venous thrombosis or DVT. He had a family history that was positive for breast cancer. He was a smoker, and he had a strong history of alcohol and nasal cocaine abuse, which he quit 6 months ago, and he had conveniently quit smoking about 12 days ago. So at least he's trying. So their physical exam here, you can read these. I'm not going to go through everything, but you can notice some elevated heart rate, elevated respiration rates getting kind of high there, just at rest. Temperature was higher. He wasn't in any apparent distress. He had pinpoint mark on the inner left thigh with visible surrounding erythema. His left thigh was palpable, had palpable warmth and tenderness. He had no fluctuants or masses, so talking about some swelling there. He had a negative Holman sign, and his left knee was tender, but no warmth, erythema, or loss of motion, and his neurovascular status was intact. So, guys, anybody want to just shout it out there? What do you think it is? Everybody stumped? It's okay if you're wrong.
I had a question.
Yes.
The pinpoint mark on the skin that was like in the center of the area that was swollen and red.
Yeah, that's a good question. It actually, they didn't describe whether it was or not. They just said that he had a pinpoint mark on his arm, and it didn't look like there was any signs of infection around it. So, good question, though. But yeah, they weren't that descriptive.
What would make him hurt?
I'm sorry?
What would reproduce this pain as far as ambulation or range of motion, or with a constant pain regardless of his posture or mobility?
Good question. I think that's where you have the advantage over this PA, because the PA, besides checking the knee range of motion, didn't check any kind of other issues with what would exacerbate the pain. Just looked at what medications may or may not have helped. So we don't have any of that information. And I think that's where, you would have a movement hypothesis and the PA doesn't. So good question.
I'd be concerned about an inflammatory or an infectious process. I've never heard of this item number D. I'm not sure what that is.
Yeah, I would be right there with you. I was completely lost as to what that was, too. So wouldn't have probably been my first guess. So I'm just going to, for the sake of time, we'll go ahead and move on here. And it was actually a DVT of the less common femoral 2 popliteal vein, so a pretty large-sized DVT. And then they also determined that through a comprehensive ultrasound, and they took serial ultrasounds, serial Dopplers. They noticed in here, or they mentioned in here, that many patients have more than one acquired risk factor for thrombosis, and they list 6 prevalent medical characteristics, which we could kind of compare to what we have in the ISC. But they said more than 48 hours of immobility in preceding months, hospital admission in the last 3 months, surgery in the last 3 months, malignancy in the last 3 months, or infection in the last 3 months. So it must have been a study that they looked at 3 months out. So. Differential diagnosis, they had thought about cancer. Did anybody else think that, maybe? Because they had the history of breast cancer in the family, and then he had also had a weight loss of 30 pounds in 3 months and wasn't trying to lose weight. But they said the CT scan was unremarkable for that. Also compartment syndrome we could have been thinking about, but usually due to trauma, bed rest, or blood dyscrasias, and he didn't have any of that in his history. Also, he didn't have pain out of proportion to the exam, and so when they did the passive range of motion testing, that didn't seem to exacerbate his symptoms. Could have been cellulitis, but simply that would have been something they would have ruled out with an ultrasound. So the take-home from this case that they mention is that cases like this remind clinicians to keep their suspicions high and differentials broad. And even though your initial diagnosis might be correct, you don't want to overlook any threatening causes. And if they hadn't suspected the DVT, then the patient could have went home and later presented with a PE. So definitely serious case, glad that they caught it. But for the physical therapist, our take-home is that we really want to be able to have a movement screening hypothesis. And if we think that there's heightened, possibility that this person has a DVT, then we want to refer them appropriately. And here's a great tool here, this Wells Clinical Prediction Rule. Just a nice way to add some objectivity to your findings. There's still, I think the ISC even brings up that there are some discrepancies in what things people think are the most important to use. But this is definitely a great tool, and you can see that it gives you some predicted risk down below there. If you have more than 2 of these variables, or a score of 2, more than a score of 2, then there's a 75% predicted risk here. So definitely want to refer that person. So as I was kind of connecting this with with the vascular and bone components, I just wanted to mention that I do work on the weekends in an acute care setting, and I want to take you through a little thought experiment here. So if the patient went to the hospital, this is probably what's going to happen. He's going to get hospitalized for a few days. If they find that if he has a lot of comorbidities, he may be even in there longer, maybe for a week or more. And physical therapy is going to consist of walking once around the unit and having lower extremity exercises that they may or may not do once a day. The rest of the time, rest of the 23 hours out of the day, they're going to be sitting in bed. I checked. I like this here. I checked with I checked in with a broken hip, and food poisoning came later. So kind of humorously talking about how patients really do a lot of times go into the hospital and they go in with one thing and then they come out with pneumonia or MRSA or DVT or some kind of pressure ulcer. And so, you know, once there's a doctor by the name of Dr. Life, and he writes this book called The Life Plan. And I don't agree with everything he says, but he does bring up a good point. As a doctor, he says, if you want to stay healthy, then stay out of the doctor's office because, you know, it's kind of a downward spiral from there. And I'm not going to read through every word here, but I actually got this from a PMNR board study guide. So I just kind of randomly found it online, and I thought there were some excellent points that I would bring up. I didn't put down everything on here, but I did just pick some of the highlights. And so you can see with immobilization that strength can decrease as much as 20 to 30% during only a week to 9 days of bed rest. And even on a daily basis, you could be losing 1 to 1.5% strength. One contraction or one thigh contraction a day at 50% of maximal strength is enough to prevent this decrease. Actually, it could be a contraction, I assume, of any joint. All of these changes in can lead to a reduction in muscular endurance as well. Makes sense. And muscles distanced from the site of injury even show altered strength and recruitment patterns. So, you know, as physical therapists, I think that we would be the ones who hopefully identify those regionally interdependent variables. So if the person has thigh weakness, maybe we want to be looking at the hip, looking at lower extremity biomechanics, of course. And there was one study that was really interesting. I didn't include it in here, but they talked about how muscle torque could be affected. And what they did was they strapped their subjects to a bed for 5 weeks and only allowed them to sit for bowel movements. So I don't know where this study took place, whether it was in, during the Cold War in Russia, but it just sounded like an extreme study that they would strap the people down to the bed and that the people would agree to this for 5 weeks. It'd be very boring, especially at the time. I don't think they had iPads or iPods. So when we look at bone and joint, we can see that there's a lack of gravitational force and muscle pull on bone causing osteopenia. And you can even see that with subjects in space. Calcium excretion in addition to phosphorus loss causes atrophy and a reduction in fracture threshold. So we're going to be worried about fracture in these patients. And then you're going to be thinking about balance as well, falls risk. Articular cartilage begins to deteriorate due to a lack of nutritional support. And in as little as 2 weeks, immobilization causes ligament strength to decrease, compliance to increase, and collagen degradation to increase. So just kind of tying in with some of those ISC ideas that you've been reading about. I just thought this was interesting, looking at effects of other systems in the viscera. You got the gastrointestinal, genitourinary changes, pulmonary changes. I'm going to kind of go through those quickly there, but you can refer to them. Cardiac changes, right? Stroke volume can decrease, big one. Then the integumentary system, you can have skin atrophy and pressure sores. So here's your new patient who just got out of the hospital. Anybody know what movie he came from? Let's see, The Shining. Yep, exactly, Matt. Thanks. So treatment considerations for this patient, as we're thinking about this patient with some vascular issues. A lot of these patients can come out with post-phlebitis syndrome, also known as chronic venous insufficiency. And so we're going to be thinking about edema management, having them use compression wraps, maybe doing some retrograde massage, maybe using some, emphasizing ankle pumps, things like that for them to, and actually walking, giving them a walking program is really going to help with that. The ISC, I believe, mentioned heat over cold modalities because of these people having this compromised vasculature. We're going to think about gradual mobilization, and the action of the muscle pump is critical, as your ISC talked about. We're going to want to maintain passive range of motion, and this is where, Dr. Duvall really stressed this through the program. You want to really determine the end feel and then mobilize or stretch. So we're going to be mobilizing if it's maybe a capsular restriction, stretching if it's more of a viscoelastic end feel and we have shortened muscle tissue. So I just emphasize here, don't be a PT, as in a personal trainer, who's just going to stretch the person, but determine what the end feel is. You're going to want to assess for prior physical levels and educate on recommended guidelines. So maybe using something as simple as a ACSM guidelines for activity through the week, getting moderate activity most days of the week. You want to assess for psychosocial variables, socioeconomic variables, anything that might impact their long-term outcomes. And then you're going to also want to assess for risk factors. I know in my clinic, I try to use it on as many patients as I can, but I have this little screening tool where they just, I go through with them to kind of remind myself, because I'm usually working on movement-based impairments, but, am I checking their blood pressure? Am I asking them questions about any kind of increased risk variable, factors that might increase their risk for, cardiovascular disease, stroke, things like that. When we're looking at cartilage, the ISC, I know I tried to bring that out a little bit here. They talk about factors related to joint loading or forces. Just talking about the magnitude of loading is critical. So think about body weight, ground reaction forces, using lateral wedges to maybe unload the medial compartment in the knee, using cushion shoe wear, assistive devices. And then you're going to talk about in your on-site courses about the biomechanical vital signs. So we're going to kind of want to look at these 23 data points that Dr. Duvall talks about and assessing, how lower extremity biomechanics might be contributing to increased stress at the knee, or whether a leg length discrepancy is going to impact stress at, or increase forces at the hip, leading to premature OA. So also factors related to the area of load or force application of the articular cartilage. We're going to look at rate of loading. So the ISC discusses how most studies say avoid high-impact activities, at least early on in somebody's rehabilitation, and definitely with these patients that have osteoporosis to avoid that. You're going to want to think about joint mobilization and be maybe a little bit more critical in how you do that. So are we going to be using compression or distraction with this patient, or are we going to be using some kind of cyclic loading, unloading of the joint and getting that person, stimulating the chondrocyte activity, stimulating the proteoglycan synthesis and all these other things, these microbiological things that we're going to be stimulating through macrobiological processes. We're going to be looking at joint mobility, improving, which actually will help them to improve their functional capacity. So think about something as simple as a 6-minute walk test. I believe, if I'm correct, that hip extension range of motion is actually correlated more with a person's performance on the 6-minute walk test than the actual cardiopulmonary function. So let's think about that with our patients. How many patients come in all kind of leaning over with that poor posture, and they've got a joint capsule restriction, or they got a hip flexor contracture, and how about just restoring that range of motion and improving their quality of life? That'd be great. So thinking about bone, I'm not going to go over all of this here, but, some of the sequelae that can happen because of fracture or mobilization. Even afterwards, we're going to be wanting to do our neurovascular screening, so thinking about that with your medical screening hypothesis, looking for diminished pulses, skin discoloration, I just like the word poikilothermia for coolness. Increased swelling, ischemic muscle pain. We're going to be wanting to look at the possible nerves that might be affected and the vasculature that might be affected in these regions. Excuse me. So, for instance, we're going to be looking at the femoral nerve if they have a pelvic or proximal femur fracture. Also, the sciatic nerve could be affected, or even the common perineal or deep perineal muscles. So, looking at your muscle strength testing in the lower extremity, as well as changes in vasculature, is going to be very critical. You also can correlate that with their function. So, with the patient who has we'll take the femoral nerve, for instance. They might have difficulty with ascending stairs or sit-to-stands. In the patient with the sciatic nerve problem, they might have a steppage gait or a foot drop or inability to run. With the fibular neck fracture, we might be looking at a compromise of the deep perineal nerve, and they might have foot drop and a steppage gait as a compensation. So looking at avascular necrosis, right, that's something to consider as well. If the person has a prolonged complaint of pain and discomfort and exhibits signs of swelling in the fracture area, this is going to be beyond the normal anticipated reparative stage. And then with osteomyelitis, we're going to want to be looking for, this patient status post-open fracture who's at increased risk for osteomyelitis. So I like this guy. His name is Gallus, and he was from the 2nd century, I believe. And in PT school, you might be familiar with the concepts of Ruber, tumor, we've got Pallor, and we have Dolor. Correct? Is that all of them, I think? Ruber, yeah. So anyway, Gallus, he proposed a 5th sign of inflammation, and that was functional loss, or functio laesa. Sorry, my Latin is a little bit rough there. But yeah, so I'm sorry, it was Dolor, Rubor, I think it was Calor, I forgot, and 2 more. So there's 4 Latin words for signs of inflammation. But I think, he's really pointing to an important fact that functional loss can be indicative of some kind of pathological issue that's going on, or it could be causing pathology. So we need to know when to treat and refer, or refer immediately. And here, just kind of driving that point home again with the Nagy model of disability, that impairment, although pathology drives impairments, also impairments can drive pathology. So you might have this patient with this systemic hypokinesia because they have limitation in range of motion or limited muscle endurance. So these impairments can drive the person to have decreased activity, thus inciting all kinds of microbiological changes, which can cause increased risk for cardiovascular disease, stroke, cancer, all kinds of diseases. So remember, at the end of the day, with patients like this, it's about the forest, right? We want to think about the fact that if anybody's familiar with the phrase, one should not lose sight of the forest for the trees. So we might be just looking at a knee joint, but we want to be looking at the whole patient from a biomechanical perspective as well from a medical screening perspective. And then also tying in our ICF model here to consider the individual in their context, right? So we're not just this static individual, but we're part of this dynamic flow of stimuli and things that are coming in and out and are affecting us, especially thinking about psychosocial variables, which are often overlooked, I think, in a context of an outpatient PT setting. And then if you're just interested in a really great video on the future of regenerative medicine, this is from a site called TED.com, one of my new favorite sites. And they have a lot of smart people that talk about smart stuff that's over my head. But this lady, Molly Stevens, talks about a way of basically injecting materials underneath the periosteum of bone, and then the bone will actually, within 30 seconds, create a gel-like calcium substance that will start to, it'll release the stem cell, or the stem cells will be activated and start to grow more bone. And then what they do is there's a line of demarcation between the old bone in this pocket and the old bone and the new bone that's in this pocket here, or this cavity. And then the doctor can come in, the surgeon can slice it away easily. And it actually has been shown to decrease the pain levels that patient had at the harvest site. So thinking about iliac crest harvest, how patients can often have pain for up to 2 years afterwards. This is just a really cool video, so if you have time, watch that. And it's about 1:59, so probably not time for questions, but that's it, guys.
Guys, that was outstanding. We are at the limit of our time, but I would like to say what a great job you've done to integrate vascular and nerve with bone and cartilage, and really setting us up a nice segue into ligaments and tendons, which is what we'll do in our next ISC session. So great integration and synthesis, great practical application here, great critical thinking and clinical reasoning of all relevant variables, indicative of the modern manual therapist who has a focus on clinical decision making, considering and basing it in the most basic of sciences. So that being said, that's the end of this session. Great job, everybody that participated. You all made this excellent. And I can't thank you enough for your attendance. Dr. Barker, thanks for guest lecturing and putting a great PowerPoint together. And we look forward to our next session where we're going to focus on 14.2.5, 14.2.6 on ligaments and tendons as we take this journey continuing with the most basic of sciences that govern our clinical decision making. Thank you, and everyone have a wonderful week. See you next week.
Thank you.